everyone, and welcome to another episode of the hashtag See Arthritis series. We're very fortunate today in this series to have Dr. Stephanie Keeling sitting with us, who's one of the speakers at the workshop on recent developments in the pathogenesis of inflammatory arthritis. And her focus is going to be on lupus and its not just its origins and development, but specifically on lupus and pregnancy. And she's going to tell us more about that. But welcome to the studio.
Thanks for having me.
Yeah, it's great. We only just spoke a few weeks ago, so we're thrilled to see you again, Dr. Keeling. Let me tell our audience just a little bit about you. So Dr. Keeling is a former board member and current member of the Guidelines Committee of the Canadian Rheumatology Association and is a member and treasurer of the Canadian Network of Improved Outcomes in Systemic Lupus Erythematosus, or CANIOS. CANIOS is a Canada-wide group of rheumatologists collaborating to study Canadian SLE, so systemic lupus erythematosus patients. She's also the treasurer of the Lupus Clinical Investigation Network, or LUCIN, which is a North American network of rheumatologists who are working to improve the lives of patients with lupus. So, audience, we've got a real expert here with us today. We're very honored to have you, Dr. Keeling. So we're just going to dive right in as we normally do with the hashtag See Arthritis event. So tell us a little bit about this workshop that you're participating in as one of the speakers. I know there's, I think you're one of 4 speakers in the workshop, and just really eager to hear what you're going to cover.
So the CRA has many awesome workshops. And in fact, while I'm in this one, there's about 4 others going on that I would love to be at. So this particular workshop is looking at sort of different aspects of inflammatory arthritis. And so the colleagues and I are talking about different pieces of it. And so each of us is presenting about 10 minutes of our work, some research that we've done. So for me, I sort of fit in this no man's land of pregnancy and some work we did in Alberta, just looking at the impact of having a rheumatic disease. So the big focus is, like, we looked at Albertan women who have lupus, who have rheumatoid arthritis, and also 2 other diseases, psoriatic arthritis and spondyloarthritis. And we sort of were evaluating what happens to them in pregnancy, what are we doing with medications?
Yeah, that's really interesting. I know you have a real focus on lupus, but to say, well, how do lupus patients fare compared to these other prominent inflammatory forms of arthritis is super, super interesting. So tell us why, specific to lupus, not to discount these other diseases that were part of your study. I know you'll touch on those, but why is lupus in pregnancy sort of such an important disease area to do research on, and ultimately, I guess, to discuss with patients compared to other inflammatory forms of arthritis?
I would say probably because like over 90% of lupus patients, for the majority of the cases, are women. And often, whether you started in your teenage years with the diagnosis, or probably the most common time women are diagnosed is in childbearing age. And
Right.
so I didn't necessarily start out studying pregnancy or reproductive rheumatology, but inevitably that has become a big part of my practice for largely lupus and also rheumatoid arthritis, because people get pregnant and they have the disease, and the disease can rear its head during pregnancy, before, after, and it has so many implications on how women choose to treat their lupus, and also how they choose to try to get pregnant or not, and then all the other reproductive issues that go around that.
Yeah, I know that in rheumatoid arthritis, for example, when a woman becomes pregnant, often her disease goes into remission or can go into remission. Is
Mhm.
that the same in lupus?
Great question. And not necessarily. So it's a
Okay.
much more mixed bag. Like, we often would recommend that somebody with lupus, if it's quite active, that's not a good time to try to conceive. And so the general consensus, based on like registry data, because it's not like you can do a clinical trial in this because it's not enough people, and for other reasons. But we know that if we have somebody who wants to get pregnant, we recommend that they're in the lowest disease state possible. So ideally, like no activity, and on pregnancy safe medications, and that they're quiet for a long time. But we also know sometimes that's very hard to achieve. So then you're dealing with having to deal with somebody with some active lupus, and that in and of itself can lead to significant issues for the mom and the neonate, the baby.
Yeah. So, it's interesting, the public or patients ourselves, we don't think of knowledge like this necessarily as innovation. We always think of, the medicine's end, right?
Yeah.
Or the basic science end. But knowing how to prepare someone to enter into pregnancy is a breakthrough, is an advance, which I think is really emblematic of the theme of this conference. Tell us, Dr. Keeling, what are some of the challenges with getting pregnant with lupus, aside from the activity level you just spoke about in trying to be at a low disease activity before becoming pregnant? And then how do you manage the disease during pregnancy? What are some of the things that you do to work with your patients to achieve successful, pregnancy and outcomes at the end of the pregnancy?
Right. Well, I mean, I could give an hour talk on this,
Yeah, I know you could. Yeah.
but I would say that there's multiple things. So like the challenges are trying to convince people that there are pregnancy safe medications, because there are. I think it makes sense. A lot of women try to go all natural in pregnancy, as an example, because we care so much about having, a healthy child or children. And so there's a lot of, I think, upfront need for good education on it. It has to be based on good information and data to say why we want to do that, which is part of the research piece. But there is making sure that someone's getting pregnant when it's a good time. There's making sure they're not getting pregnant on several medications that are often pivotal in, for example, treating kidney lupus or lupus nephritis. Some of these you cannot get pregnant on because they do cause problems. And so we often have to counsel people on transitioning them off what we call teratogenic medications that can cause malformations in utero, and switch them to pregnancy safe meds. There's also accidental pregnancies. Pregnancies happen,
Yeah.
and sometimes people don't think they can get pregnant when their disease is active, but it can happen. And even before and after, a big thing relates to even like contraception and what's safe, because some contraception is not as safe because it can flare lupus. And so timing what's a safe method of birth control to then when you want to switch off of it so you can try to get pregnant. And then in the background, there's also, can they get pregnant? So
Yeah.
while we don't necessarily say lupus makes you less fertile, it's probably true in general when someone's disease is active, not only in lupus, but even like rheumatoid arthritis or other rheumatic diseases, you're statistically less likely to get pregnant, but it still can happen. It's timing, like understanding that if they can't get pregnant and you've played around with medications and they get in a flare, that's problematic too. And then some
Yeah.
people now are going for fertility treatments as well, and some of them may be more risky to flare disease. So those are just like a summary of that. And then if they get pregnant, there are certain features that we screen for, particular antibodies that might increase their risk for miscarriage or like pregnancy loss. And then the other one is there's an antibody that we have to screen for that could cause the baby in utero to have what's called neonatal heart block, or a form what's called lupus, neonatal lupus.
Wow. Okay, so that
It's a
is
lot.
quite complex. That's a Paul's notes, and it's still complex for the lay public.
Yeah.
That is incredible. It's like working a Rubik's cube, basically. You're just trying to line everything up to try to get pregnant, to have a healthy pregnancy, and to ensure that baby is well at birth and through life. Um, Tell us a little bit, Dr. Keeling, about the changes you've seen, because I know good, healthy pregnancies happen. So it is good news today, with all of this planning. But talk to us about what you've seen over your career. I mean, you've been a rheumatologist for a number of years, and you certainly have seen advances. For you, what's been the most important change sort of from 10, 20 years ago?
Uh, yeah, so this actually I think is my 20th year of practice.
Oh, is that right?
Yeah. So I know, my goodness, time flies when you're having
Yeah.
fun, right? So I think a increased understanding by maybe more rheumatologists, and then our colleagues like in obstetrical medicine, obstetrical gynecology, and primary care who treat pregnant, like who have pregnant women in their practice, probably understanding that there are certain medications that are safe to continue. The main one would in lupus and in rheumatoid arthritis and other diseases would be anti-malarial drugs, and then that
Like
like
hydroxychloroquine?
hydroxychloroquine.
Yeah,
That's the
okay.
main one, exactly. Yeah, also known as the trade name would be Plaquenil.
Plaquenil.
And yet, and so I still think that's some of what our research that I'll present shows, is that despite us knowing this, like I would say the uptake's better. In our research, we only showed about a quarter of women were filling prescriptions for antimalarials while pregnant. And really, I think that number should be closer to like break 50%, 60, 75. So I think my interpretation is that's low, but I believe that has improved over the past 20 years. We have better liaison with a group of internal medicine doctors called obstetrical medicine. So they share a lot of our patients and help facilitate, like give them preconception counseling, especially if it's not just lupus that they're dealing with. They also help be like the route to if they need maternal fetal medicine. These are the guys who monitor the baby while in the mom to make sure, looking for neonatal lupus as an example, and other things. So I think that has come to improve. In other rheumatic diseases, some of the biologics are safe. We don't know this for lupus, but for example, rheumatoid arthritis, the TNF blockers can be used throughout pregnancy and breastfeeding. And that uptake is still not great. Like we saw, it was only like 8% of people with rheumatoid arthritis were still taking that in pregnancy. But I think that uptake is increasing as we see that the safety in like registries and observational studies are good.
Yeah, we've had a number of members come to us asking about pregnancy, for example, in RA, and supported them with information that's evidence-based to go talk to their rheumatologist
Yeah,
about certolizumab or Cimzia, which has
right.
strong pregnancy data and has an indication for use in pregnancy.
Yeah.
And I'm always so thrilled to hear back from those people saying, I just had my little girl and she's so happy. And yeah, it's really incredible. Are there any future studies planned for, for example, that particular biologic being studied in lupus, or not yet?
So good question. So interestingly, like the TNF blockers, like the Cimzia you brought up,
Yeah.
they don't work in lupus. So there's obviously some differences there.
Okay.
So the biologics that are certainly available so far in lupus would be something called belimumab, Benlysta, and then the other one is anifrolumab, also known as Safnello. And
Right.
those have not yet been tested. Like there's been registries across the country. I often go to this. There's a rheumatology pregnancy conference every 2 years internationally, so we usually attend that. And there are registries reporting women, for example, conceiving on belimumab and having successful pregnancies. It's not an endorsement that it's guaranteed it's safe. We don't know that. But I think over time, those studies will come. We don't know anything about the newer biologic anifrolumab or Safnello, so it would not be recommended.
Right.
Uh, but I think the hard part for what we know is reasonable. So drugs like we mentioned hydroxychloroquine, and
Right.
there's a couple other immunosuppressants they use in lupus. Something called azathioprine can be used in pregnancy and breastfeeding. I think the biggest thing where we have work to do is having trust by the women that there is data for this, because pregnancy is a very unique time, right? And you're never going to have a clinical trial of a drug to show this. And there's a lot of misinformation, as we know, everywhere, but even it still applies here, where a patient here, his friend says, oh, you're on anti-malarial, that's going to make you blind and it might make your baby blind and stuff like that, which is not true.
Yeah.
There's still concerns, of course, we always monitor for, but we know we have good data for drugs like anti-malarials and also for azathioprine, that I think that work to increase that knowledge also in primary care and also uh, patients who want to get pregnant is still it takes a long time. It's important to spend the time and counsel people.
Yeah, I was going to say probably as we wrap up our time together, Dr. Keeling, because we know you got to get back to the conference and keep teaching people what to do with lupus and pregnancy and lupus and all other aspects of rheumatic disease. But it seems to me that one of the big innovations, just hearing you talk, has been team-based care. So being really plugged into obstetrics now,
Yeah.
having that conversation be very robust and in-depth. Would that also extend, of course, to the discussions you have with your patients. I'm sure those have changed dramatically today versus 10 or 20
Yeah.
years ago. I mean, the whole concept of patient engagement and patients being the quarterback of their care must have changed the conversations you're having with women, particularly with lupus and who want to get pregnant.
It is, it is. And I think the key is repeated education, having materials. Like the scary part is, like we know from the Alberta data that women with lupus had the highest rates of cesarean sections, preterm births, small babies, and ICU admissions. And if that's up front what we're saying, that's really scary, right? It's
Yeah.
terrifying. And so sometimes that actually scares people out of trying. But I think with the ability to say this is serious, it's not something that you should just ignore, but there are methods, especially with team-based care, and everybody kind of believing in the same and understanding what's true and what's not. And that's where hopefully like this research shows that. And we see there's room to move in things that are safe in pregnancy and medications, that I do think the trajectory at least is going in the right direction.
Yeah, that's fantastic. I guess having a great relationship with a rheumatologist like yourself who has huge expertise in this area is certainly key to having peace of mind going
Yeah.
into even the conversation. And trying to check your fear at the door and having an open conversation with your rheumatologist or lupologist is really going to be quite central to successful pregnancy. So we want to thank you so much for your time, for your expertise, and for all of the great caring. We know we have many members who write to us, and we have lots of people who say, "Oh, I love my rheumatologist, Dr. Keeling, fabulous." So thank you so much for all that you do in advancing science in this area, but also in the tremendous care that you're giving and working with your patients to deliver. So thank you so much, Dr. Keeling, and have a great rest of meeting.
Thanks, and thanks for doing this. It's really
Yeah.
important.